That's great, thank you. So yes, I'm going to speak to you today about the Special Olympics. As Emma says, I'm a lecturer at Glasgow Caledonian University, but I've also been volunteering with the Special Olympics since 2005, and I'm one of the clinical directors for Special Olympics GB. You'll see at the top there, I've actually got the athlete's oath, and I like to put that on all my presentations for the Special Olympics, which is let me win, but if I cannot win, let me be brave in the attempt. So the Special Olympics, what is it? So the Special Olympics is actually an international movement or charity which offers all year round sports training and athletic competition for children and adults of all abilities with intellectual disability. And what that means is that some people get that confused with the Paralympics, where actually it's not the Paralympics, which is about physical disability. It's nothing to do with their physical disability, it's to do with intellectual disability. It was founded in 1968 by Eunice Kennedy Shriver, who was actually JFK's one of his sisters. And she started working with kids with intellectual disability. There was a gap there and a need for summer schools in America for children with intellectual disability. So she started running these in her garden, and then she decided to create a bigger movement. And the first games were in 1968 in Chicago. And it was about shining the light on ability and not on disability. It then became part of an international movement, and it was established in Great Britain in 1978. In 1998, the International Olympic Committee granted official recognition of the Special Olympics. So this was a big thing because it's actually not funded by the IOC, so it doesn't follow the IOC calendar, so it doesn't run in line with the Olympics or the Paralympics. It is a separate organisation, but it is recognised by them. And one of the reasons it's not recognised by them is that it's not about elitism, it's not about being an elite sports person, it's about participation for the Special Olympics. It does, however, run similarly in that it has national and international summer and winter games. So every 4 years we have our summer games, and every 4 years we have winter games, nationally and internationally. It's a volunteer-based organisation, and in GB we've got 105 local clubs and branches throughout, with around 4,000 volunteers, and over 10,000 athletes are involved. The need for the Special Olympics in Great Britain, this is just some of the figures part, that there's 1.5 million children and adults with intellectual disability in Great Britain. It's the most common disability, and it's due to grow. There's 200 babies are born with intellectual disability each week, and children with an intellectual disability are socially excluded, and 8 out of 10 of those are bullied, which is quite a surprising figure. 1 in 2 families of a child with intellectual disability live in poverty. 1 in 3 people with intellectual disability are obese, and over 80% of the adults with intellectual disability don't achieve recommended levels of physical activity. And this is one of the things that Special Olympics GB are trying to tackle. They've just launched their new 4-year strategy called Inclusion in Action, and one of their main things is about growing participation and getting more athletes involved, as well as generating sustainable funding, because as we said, it is a charitable organisation, and that's one of their main aims and one of their main blocks as well. And now the bit that I'm involved in is what we call the Healthy Athletes Programme. So the Healthy Athletes Programme, it was about 30 years after Special Olympics was actually founded, and they introduced this programme, which is basically tackling the health inequalities that have been identified within this population. There are a number of professions involved within the Healthy Athletes Programme, and we've got quite groovy names, trying to be quite trendy. So as for podiatry, we are called Fit Feet, and we have dentistry involved for Special Smiles. The opticians are opening eyes. We have audiologists involved who are healthy hearing. The physios get to be fun, so they're fun fitness. We also have health promotion and MedFest, which is the medical side of it, looking at blood pressures, BMIs, and that sort of thing. Now, the Healthy Athletes Programme, it was officially launched in 1997, and it started off with special smiles and also opening eyes. But Fit Feet got introduced in about 2003. And so globally, the objectives for healthy athletes are to improve access to for healthcare, making referrals or recommendations for follow-up to local healthcare practitioners, training healthcare practitioners and students about the needs and care of people with intellectual disabilities, collecting and analysing and disseminating data on the health status, and also advocating for improved health policies for this population. So because we do a health screening of these athletes, we screen it internationally, so it's an international movement. So we're all collecting similar data, and it means that by looking at that data, we can try to actually influence policy and practice for the healthcare needs for this population. So looking into Fit Feet, you'll have mentioned I said screening there, and you might be wondering what I mean by this. And what it is, the actual Fit Feet and what the other professions also do is a screening programme. We don't treat, so it's slightly different than being a podiatrist involved in the likes of the Commonwealth Games or the European Games or into the athletics side of things. If you're involved in these sort of events, you treat the injured athlete that comes in to see you. And this isn't what the Special Olympics Healthy Athletes Programme is about. It's about screening all athletes, not just the injured. We look at all of the athletes. So what we do is we have a screening form of which the data collected, as I've said, is the same internationally. So what we're collecting, we can compare our data with other countries also. So it gives us big data sets. So that's one of the positives around this screening programme, is we do have big data sets on this population. One of the issues around that data set, I would say, would possibly be sometimes around the reliability. I'll talk you through more about what we actually do screen for and what we're assessing on the athletes, and you'll see that perhaps sometimes the reliability of the data, because of the number of volunteers that we have and also the types of volunteers that we have, it's quite subjective, some of the data that we're collecting. A lot of the volunteers are students. We also have Special Olympics is globally and in sort of more third world countries where podiatry actually isn't a profession. So those who are assessing the foot and ankle may be physios, they may just be healthcare workers, nurses, students. So again, the actual experience of the screening team can be changeable depending on where the games are being held. So just talking you through the screening process. So the athletes arrive, and we first of all measure their feet. We use the Branix device. So this is one of our objective measurements that are our only objective measurement that we take. So we measure their foot, and what we do is we use that to compare it to their footwear to make sure that their footwear is fitting and is fit for purpose. The athlete then moves on to the next station, where we assess their feet for dermatological or any sort of bony and structural deformities. So we look for things like tinea pedis, verruca, any nail conditions, any toe conditions, HAV, clawed toes, lesser toes. We also carry out an open kinetic chain assessment where we look at joint range of motion also in that station. The athlete then moves on, and we do a static assessment of them, looking at their foot posture and just assessing of what their foot posture is presenting with. Then we move on to the gait assessment, where we have a look at their movement pathways. We're looking here to see if they've got an abducted gait, an adducted gait, have they got a sort of stability within their foot, is it excessively pronated, supinated, that sort of thing is what we're looking for. You see here we've got the athlete walking over the pressure plate. We often have the pressure plate there, but it's not always available. Sometimes, again, it is just with the eye. And also with all these other assessments, it is subjective. It is the clinician who's assessing. Things aren't sent off to mycology to check to see if it's tinea pedis or onychomycosis. It is taken on clinical signs and symptoms. The patient ends up, the athlete I should say, ends up going off to our health promotion area, where we have purpose leaflets for health promotion on nail care, general foot care for them. And there's usually some goodies there that we have donated from different companies that we've begged, borrowed and steal from, some stickers and things for them. At the international events, we are usually quite lucky and we get to give them footwear, so they get a pair of trainers that is fitted for them, which is usually a good draw and attracts them to come for a screening if they know that they're going to get a new pair of trainers. So we're usually at the world events, we get to fit them with new trainers, which is good. At this health promotion station, this is also where we would write a prescription. So if we wanted to refer them on to a local podiatrist or another healthcare physician for any ongoing treatment or care for the athlete. So as I say, we don't treat, we are assessing and then recommending. So just an example of one of the most recent screenings. Unfortunately, our national games were meant to be in Liverpool this year and they got cancelled because of this dreaded virus that seems to be chasing us around. But we managed to have a world event in 2019 in Abu Dhabi, which was our World Summer Games. You'll see here, I was talking about the trainers that we were able to fit. This is a version of the trainer that were given in Abu Dhabi. So all the athletes were fitted with this. Although it's quite funny, by the end of the week, every athlete's walking around in exactly the same pair of trainers. But this is sort of an example of the footwear. You can see at the top here, I've got up that we screened 2,856 athletes in a week. So you can tell we were busy. So we had lots of volunteers to help us get through that. One of the reasons that the form, we don't have too many objective measurements in there is also that would take a lot of time. So one of the other benefits of our screening tool is it's fast. We can get through a lot of athletes quite quickly. You'll see here in the photographs that the one on the left here is our screening area. So this is where we carried out our structural assessment and dermatological assessment. And you'll see in the back, we've got some sort of lanes taped out, and that's where we would get them to then walk up and down. We didn't have pressure plates at this event, so it was all eyeballing, and we got them to walk up and down so we could assess their gait. The picture here on the right is our waiting area. So that was all the athletes for that session waiting to come in and see us. So you can see that we were very popular at those games, and I think it was the snazzy shoes that attracted them in for assessment. This is a picture of one of our students who's just recently graduated. Glasgow Caledonian University always support me in my volunteering with Special Olympics, and they also support the students. So I managed to take a student out with me to assist and volunteer in at these games. This is him assessing one of the athletes who has a genetic disorder, Appert's disorder. And we can see here that, you know, we've got this sort of fusion of some of the metatarsals and the phalanges. You can see in this picture here that he's also presenting it with his hands, and there's also facial recognition. One of the things that we don't know about the athletes is we don't know their underlying medical conditions. I'm saying Appert's here, and it's just because it's recognisable. Down syndrome's another one that's recognisable, but a lot of the time we don't know the medical history of these athletes. So we're really just assessing what we see. This is an example of some of the other dermatological findings that we sometimes see. Because at the World events, we've got athletes from all sorts of countries that you see weird and wonderful things, and it's a great learning experience for all the volunteers that are working there. We may see some things that we don't usually see. This is a typical sort of foot posture that we may see, this asymmetry that we see in the athletes. Syndactyly is common, and another dermatological finding that we came across. So these are the sorts of things that we see in our screening. So just to talk about some of the figures that are actually published, a paper in 2012 with 4,094 subjects found that only 58% of athletes were wearing the correct footwear. The rest were either too large or too small. So this is really common within the Special Olympics, that athletes are not wearing the correct footwear. One of the reasons being, sometimes it's third world countries, so they're wearing whatever footwear they have. Sometimes it's the communication issues, so when they're in shops buying shoes, they're unable to say if they're too tight or too big. They like the colour, they're delighted with them, they're having them, and that's what happens. Also, we find, and what we've got to watch out with the Special Olympics is they're all living in shared accommodation, and very much so they sometimes just put on somebody else's shoes. So they could be sitting there with somebody else's shoes on. Specifically when we get to the end of the games and they're all wearing the same shoe, because we've fitted them all with the same shoe, that it's very difficult to distinguish of which is theirs and which is somebody else's. Some of the other findings we can see here on the dermatological and structural findings, we can see there's a high prevalence of certain things here also. So we can see there's a high prevalence of onychomycosis, tinea pedis, a high prevalence of this compared to general population. Looking at structural findings, we can see when they're standing, you know, we've got a sort of high incidence of pes planus here. Metatarsus adductus is a high incidence at 2.9%, where general population is 0.1%. Brachymetatarsia is usually 0.02% in the general population. In this population, it's 1.8%. HAV, 12.8%, where it's usually about 2.5 to 3.5% in a similar population. So we can see that we do have higher incidences of structural and dermatological findings. I'll just break it up with some more pictures. So this is a typical pes planus foot type that we may see. We've got the metatarsus adductus, we've got the cavus foot type, and our typical sort of Down syndrome type presentation of laxity and this sort of genovalgum sort of stance. On our biomechanical findings, there may be some people in the audience cringing over some of the terminology here. So what we've got to remember is this is a sort of international organisation, and the terminology has to be recognisable across the board. And so the reason for overpronating and supernating, I know that's debatable, but for the purposes of the Special Olympics and its form, we can see that we have a high incidence of that overpronation during gait, so that sort of medially deviated axis in gait. We can also see that we've got a high incidence of abducted gait also. And one of the things we can put that down to is a lot of the conditions similar to Down syndrome, where we have laxity of the ligaments, can cause a lot of these things that we're seeing. But what slightly contradicts this is the ankle joint range of motion. We've got a really high incidence of restricted ankle joint, which is sort of double what would normally be in a sort of matched population. And also first MTP joint restriction there is also highly elevated in this population. Because we've got to remember they're children and adults, so it's quite a young population. This is just another study, a much smaller number of 46, but it was done in the Czech Republic. So most of those other studies I was talking about were American-based populations, but this one in the Czech Republic published some of their findings, and we can see it's very similar. High incidence of pes planus, high incidence of an abducted gait, Again, high incidence of restricted ankle joint, high incidence of HAV. So they did find a higher incidence than the other study of pes cavis, but the rest were all really quite similar findings. This slide is just one that I've put in. It was a more objective study. So you may have heard of the Foot Posture Index, which is a much more objective measurement of foot posture than just looking at it and saying, yeah, that's pronated. So one of what I've been doing within SOGB was I've been including the Foot Posture Index into our assessment. And what we did is we had a look at some of the foot posture indices for Down syndrome, so to try and reduce the variables, because as we've said, we don't know what the underlying condition is with these athletes, so it can be very difficult to compare and look at trends within their foot health. But because Down syndrome is recognisable, so one of our fourth year students, so this is unpublished data, I just thought I'd put it up as interest, looked at 131 athletes with Down syndrome using the Foot Posture Index. She compared right and left feet, which there's not a lot of difference between, but again, we can see, not probably surprising, but over 50% of the population have either the pronated or the highly pronated foot within the Down syndrome population. So, and very few having a sort of cavis or supinated foot type. So in summary, you'll be pleased to know, Emma, that I'm on time, I'm feeling, is that there is 1.5 million people with intellectual disability in Great Britain, and we've got 10,000 Special Olympics athletes involved in that, and we would like more. About 50% of these athletes do not wear the correct size of footwear. Nearly 50% of the athletes have skin or nail conditions. 23% of them have bony deformities, and 55% of them present with gait abnormalities. So I think that's highlighted that there are health inequalities within this population, and it may be an unmet need. It may be a met need, but it's something that I think it is good to have this data, which will help strengthen and help maybe inform health policies in the future for this population. So thank you for listening to my presentation, and there's my email address and my Twitter address for you. Also on there is the Special Olympics information if you want to get involved or know more about the Healthy Athletes programme. Thank you.
Thank you. And again, imagine rapturous applause. It's everything I want to do right now for all of our speakers this evening. It just is this different environment we're in, isn't it? But once again, Mandy, just such a fascinating topic to discuss, and actually quite a hidden population for many clinicians working in sport. So I'm always delighted to hear from you. As I said at the beginning, again, you haven't disappointed. Would you like to leave us with sort of one golden nugget? I haven't actually received any questions. Perhaps some might come in as we move on, but would there be one golden takeaway you'd like to give our clinicians listening this evening?
Get involved is my main thing. I would say is that the events don't come round, so they are every sort of 4 years for the summer games, so they're not regular, and the healthy athletes, our screening is only really involved in the bigger events because it's expensive to get involved, and we need to actually rely on donations for that, so we tend to only be involved at the bigger events. And what we try and do with the Special Olympics is we try and travel around the country, so it's not always in the one place. And one of the reasons for that is to share the love and try and to get local volunteers, because, as I said, one of the objectives for Special Olympics is about making other healthcare practitioners aware of the needs of this population, and also to train healthcare practitioners, because it's one thing I think that we do lack in our undergraduate training. It's maybe mentioned and you come across it, but it's not really a focus, is it? There's not any huge learning outcomes in the undergraduate programme. So I think if anybody, if you see any adverts about Special Olympics coming your way, please, please, please get involved. It is a very worthwhile experience and a lot of fun. Although we're busy, obviously, screening over 2,000 athletes.
Exactly, rewarding for the clinician as well, working in a big multidisciplinary team. it is going to be a great experience for anybody. I quite agree. So again, many thanks for sharing your evening and your wisdom with us tonight. And I'm going to let you go and move on to our final speaker.